Hello, my name's Ryan. I'm going to be your student physical therapist today. How can I help you? What's bringing you in?
Um, I've been having some pretty bad back pain lately.
Okay, when did this back pain start?
A couple weeks ago.
Okay.
It's not been changing or letting up at all.
Okay. Was there any specific incident that occurred a couple weeks ago that caused your back pain?
No, not that I can think of. I mean, I teach at Monsters University, and
Okay.
a lot of the same standing up and teaching, walking across campus. I have to walk further to get my smoke in because now it's a smoke-free campus, but
Okay.
they made that change like a decade ago. So
Okay. So you're smoking regularly? About how much are you smoking?
probably a pack every few days.
A pack every few days?
Yeah.
Okay. Any alcohol intake as well that I should be aware of?
I mean, at night, just to kind of de-stress for the day.
Okay. Okay, that's very helpful. Thank you for sharing that.
Mm-hmm.
How would you describe some of your back pain?
It's pretty dull, kind of aches and throbs a lot, but the main thing is it really just does not let up. Like I feel it all the time.
Feeling it all the time.
Yeah.
And you mentioned kind of walking across campus has become difficult. Any other things become difficult?
Standing up to teach my class. I teach a nutrition class.
Okay.
I don't follow it personally,
Yeah.
but I try to teach them, and pretty painful.
Okay. What kind of things make it better?
Not
Have you noticed anything?
No,
Yeah.
I mean, I try to rest just because I think that would help, but it's pretty constant.
It's pretty constant.
Yeah.
Okay. What would you rate your pain? Sitting right here, right now, 0 to 10. 0 being no pain at all, 10 being the worst imaginable pain. What would you say your pain's at right now?
Probably like a 5.
A 5. Okay.
Yeah.
And at its best, when you're feeling good, what would you say your pain's at?
Probably like a 4. It really
4.
doesn't change. Yeah.
Okay. And how about at its worst?
6 maybe.
6. So it's pretty narrow range.
Yeah.
Okay. When it's at that 6, how long does it take to come down to that 4 or 5? Would you say?
Since it really doesn't change much, maybe like a few hours or so. I'm not ever really noticing any immediate changes in it.
Okay. Kind of going back to the history, you mentioned you were smoking a couple packs a day or pack every couple days.
Mm-hmm.
Do you have any history of any like lung cancer or any cancer that I should be aware of?
No.
Okay. Any history of cardiovascular disease that I should be aware of?
I don't remember what they said, but I do have a history of a bad heart.
Okay. Any issues with like hypermobility? Any in the family? Anyone in your family been diagnosed with any hypermobility disorders or anything like that?
Yeah, my mom has that Marfan syndrome.
Okay.
Yeah.
Okay. And do you know if you have it as well, or have you ever been tested for it?
I've never been tested, but I mean,
okay.
Pretty mobile, I guess. Yeah.
Okay. Going into a couple screening questions we asked everyone. Do you have you had any issues with night sweats or fever? Waking up like a pool of sweat?
Mm-mm.
Any large changes in weight, either weight gain or weight loss?
No.
Okay. Any night pain, unrelenting night pain?
I mean, it's no worse at night than it is in the day.
Okay, but you're able to sleep, get normal amount of sleep throughout the day?
Mm-hmm.
Okay. Any issues with bowel and bladder?
No.
And then one thing I kind of wanted to circle back on, you kind of described the pain as throbbing. Can you kind of elaborate on that a little bit?
Just kind of that like achy, dull, and like kind of pulses or throbs a little bit.
Okay.
But I wouldn't say anything like sharp or intense because it's just kind of always there.
Okay. Would you say it's like fairly localized to the back? Do you ever feel like it wraps around?
I feel like it's kind of all through that like low on my back, but it does come to the sides. Yeah.
Okay. Well, kind of going forward, we're just going to do a couple tests, look at how you move, see if we can kind of identify what's causing some of your back pain, and then hopefully we can get you the help you need. Okay. So looking at the epidemiology and subjective for a patient with abdominal aortic aneurysm, typically there is a greater prevalence in males compared to females, and the risk increases with age. There has been shown to be an association with elevated levels of LDL and a history of smoking or family history of previous abdominal aortic aneurysm. There is some linkage to connective tissue disorders such as Marfan's or Ehlers-Danlos syndrome, as the aorta is made up of connective tissue and the structure of this vessel can become altered with these disorders. Subjectively, the patient will present with severe or persistent pain in the low back, abdomen, groin, or flank, and this pain will be unremitting and not accentuated by any mechanical causes or movements. They may report some swelling of the legs if their heart is if there's some sort of heart pathology involved, or if the inferior vena cava is being compressed by the aneurysm. However, a majority of these patients may or have been found to be asymptomatic, so ruling out other musculoskeletal and non-musculoskeletal conditions is going to be vital for proper referral. Alright, so going into the objective portion for an abdominal aortic exam, the first thing you're going to want to do is check vitals, so blood pressure and heart rate. Both would come back normal if the patient was having an acute rupture of their abdominal aorta. They would be hypotensive, so then you would probably accelerate into the abdominal exam. But with Ms. Wazowski's blood pressure being normal, we're going to first go into kind of a lower quarter screen. So can you go ahead and stand up for me? And I just kind of want to look at how you move, Ms. Wazowski. So can you go ahead and reach down towards your toes? Good. And then come back up. And then can you arch back like you're looking up towards the ceiling? Good. Does that bring on your pain at all?
It's just the same.
Okay. So pain's still there, pretty constant? All right. How about reaching down towards your knees? And then other side. Still about the same?
Yeah.
Okay. How about rotating?
Still about same back pain.
Same back pain. Okay, go ahead and sit up on the edge of the bed for me. And next thing I want to do is just look at your sensation, see if any of the pain you have is coming down to the legs at all. So what I'm going to do is I'll have you close your eyes, and I'm going to brush my finger across your skin, and I want you to just tell me if it's the same or different. Okay? Go ahead and close those eyes. Is this the same as this?
Yep.
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 Same as this?
Yep.
Is this the same as this?
Yep.
All right. And the next thing I want to do is just a quick myotome assessment. So I'm going to have you bring this knee up towards the ceiling. Can you hold it there and don't let me push it down? Good. And the same thing on this leg. Hold it there. Good. Then can you kick this leg out? Yep. And can you hold it there? Don't let me push you. Good. Same thing on the left. Hold it there. Good. I want you to try to bend your leg and bring your heel towards your butt. Good. Same thing on the right. Good. And can you bring your toes up towards the ceiling? Good. Hold them there. Good. Alright, so we've kind of gone through a quick lower quarter screen. Everything came back normal. She has intact dermatomes and myotomes, and then range of motion. Her pain stayed pretty constant. She did report some throbbing pain in the subjective, so kind of where my mind goes next is to kind of do a quick abdominal exam and palpate around the abdomen as well as the aorta and see if we can find a pulsatile mass in the abdomen, as well as seeing if the abdomen is distended. So Ms. Wazowski, can you go ahead and lay down on your back, maybe with your head on this side? And if you're comfortable, can you go ahead and lift up your shirt about halfway? Good. I'm going to kind of poke around, and you let me know if anything's uncomfortable, okay? And I can go ahead and stop.
Okay.
So we're just going to kind of feel around. Ms. Wazowski's abdomen does feel a little bit distended. Then we're going to go palpate over her aorta. We do feel a little bit of a pulse there. So then the next thing you want to do is you want to determine the width of the pulse. And moving your fingers out to the side until you feel no pulse. And with Ms. Wazowski, I do feel a pulse that's greater than 3 centimeters, so that would warrant a referral to either a cardiologist or a vascular surgeon so she can get further medical advice. When we move into the objective portion for abdominal aortic aneurysm, the majority of tests for this condition will be looking at the abdomen and cardiovascular function. Performing an abdominal exam will be one of the first things to do if an abdominal aortic aneurysm is suspected. So you'll be looking for a pulsatile abdominal mass and abdominal distension throughout the abdominal exam. The pulsatile mass will be located over the tract of the aorta throughout the middle of the abdomen and will likely be palpable if the aneurysm is greater than 3 centimeters in diameter. For patients with an abdominal aortic aneurysm, the greatest risk is rupturing of the abdominal aorta, which has a significant mortality rate if it is not medically managed in a timely manner. So this scenario would require emergency transport to the ER for medical management. In these instances, the patient will likely present with hypotension as measured during a vital screen, unrelenting or severe abdominal or flank pain, and the pulsatile abdominal mass over the tract of the aorta. For patients presenting with an abdominal aortic aneurysm, prompt referral to a vascular surgeon or cardiologist is required for further management.